The first talk is on chronic pancreatitis, an overview of the management by Dr. Vajira Tharanga, who is a senior registrar in gastroenterology at the National Hospital, Colombo. Over to you, Dr. Tharanga.
Thank you, sir, and good morning, everyone. And I would like to thank Zealand College of Physicians for giving me this opportunity. So today my talk will be on chronic pancreatitis, an overview of the management. So my lecture outline would be, first I will go through briefly upon epidemiology, risk factors, diagnosis, and finally my main topic of this lecture, the management of chronic pancreatitis. So what is chronic pancreatitis? It's a chronic progressive inflammation and fibrosis which leads to progressive loss of exocrine and endocrine pancreatic function due to irreversible damage of the pancreas. So roughly the overall prevalence, worldwide prevalence is about 50 per 100,000 cases. And however, in South Asia, the prevalence is actually more. Unfortunately, we don't have local data about the epidemiology, and there's slight male predominance. So what are the risk factors? Out of the risk factors, the alcohol is the most common risk factor, followed by tobacco use, and also idiopathic chronic pancreatitis is another main risk factor, which includes tropical calcific pancreatitis. Other than that, other important risk factors are autoimmune pancreatitis and obstructive causes like pancreas division. So diagnosis, when there's a patient presented with features suggestive of chronic pancreatitis, when to suspect the pain characteristic of chronic pancreatitis and exocrine pancreatic features of exocrine pancreatic insufficiency such as steatoria, or when a patient presented with diabetes and if you are suspected to have chronic pancreatitis, the first investigation of choice is imaging, which itself can be diagnostic. So the contrast enhanced CT scan of the abdomen with pancreatic protocol is the first line investigation of choice for the diagnosis. It's also important to identify complications and exclude other differential diagnoses such as other GI malignancies. So at the time of the diagnosis, you also have to investigate for presence of pancreatic exocrine insufficiency and for pancreatic endocrine insufficiency. And after confirming the diagnosis, the thorough history and examination followed by investigations has to be done to identify particular risk factors, because the modification of risk factors is an important component in the management. So in this slide, I want to highlight few things. This slide summarizes the imaging modalities available for the diagnosis of chronic pancreatitis. So as I previously mentioned, contrast CT abdomen is the first line investigation imaging modality to look for calcifications, pancreatic atrophy, and presence of duct dilatation. But the contrast CT abdomen may not be very sensitive in diagnosing early chronic pancreatitis. So in that case, if there's a still suspicion of chronic pancreatitis and if the CCD findings are not very convincing, then you can go ahead with an MRI with MRCP. So MRCP is good for detecting pancreatic ductal changes, mainly pancreatic duct dilatation, strictures, and irregularities, which are well supportive of chronic pancreatitis. And the role of endoscopic ultrasound, so it has the highest sensitivity in diagnosis, although there is a slightly lower specificity compared to other two imaging modalities. And the role of EUS in the diagnosis is when both the CT and the MRI is not very convincing, you can go ahead with the endoscopic ultrasound. So moving on to my main topic in this talk, which is the management of chronic pancreatitis. So there are certain aspects which I would like to highlight in the management. So first, the risk factor modification and nutrition, and pain management, exocrine failure, and management of endocrine failure, and finally the management related to chronic pancreatitis. So, with regard to the modifying risk factors, the most important lifestyle modification would be abstinence from alcohol and smoking. It has several benefits, which includes reduction in pain relapses, which it has shown to slow the disease progression, and ongoing smoking has shown to reduce the efficacy of endoscopic and surgical interventions for chronic pancreatitis as well. So, malnutrition is a common problem in this category, and there are multiple reasons for them to develop malnutrition, which includes exocrine pancreatic insufficiency, poor oral intake, alcohol use, and presence of diabetes. So, at the time of diagnosis and after that, periodical assessment of nutrition is of paramount importance, with standard measurements including anthropometry and nutritional screening tools can be used, and important to screen them for micronutrient deficiencies. And osteoporosis screening is also an important aspect which I would like to highlight, because they have, apart from this nutritional, the exocrine pancreatic insufficiency, they have other multiple risk factors like smoking, alcohol, the lack of physical exercise. Those things also contribute, and vitamin D deficiency and calcium deficiency would predispose them for osteoporosis and osteopenia. So, moving on to nutritional management, it is important to refer the patient for dietitians or clinical nutritionist for assessment and follow-up of these patients. And after initial assessment, if the patient is having a relatively normal or preserved nutritional status, the nutritionally balanced diet is advised. So, if the patient is having malnutrition, the one of the key component in the management would be adequate pancreatic enzyme replacement therapy, which I will describe in detail in the coming up slides. And the general recommendations for diet includes a high energy and high protein diet, which is of small meals but frequent meals. One of the important things I would like to highlight is there's no need to restrict fat. So, fat restriction is only for people who is having very troublesome symptomatic steatorrhea after adequate management of exocrine insufficiency with pancreatic enzyme replacement therapy. And there's no need of routine nutritional supplements, but micronutrient supplementation should be considered in malnourished patients. And the treatment of vitamin D deficiency and osteoporosis should be according to the recommended guidelines in these relevant areas. So, moving on to next topic, the pain management. So, pain is the most common and most disabling symptom in chronic pancreatitis, and it is seen in up to 80 to 90% of the cases, and it significantly reduces the quality of life. So, pain management is one of the key areas in management. So, what is the mechanism of pain? So, still it is poorly understood, but it's probably multifactorial. The possible causes for pain are recurrent episodes of acute inflammation and intraductal hypertension due to intraductal calculi or pancreatic duct strictures, and parenchymal ischemia. Apart from that, there's another important hypothesis that persistent and repeated stimulation of the pancreatic nerves lead to neuroplasticity or sensitization at peripheral nerve level and central nerve level. And it is also important to consider other complications of pancreatitis, especially if the pain is not responding to conventional management, or if the pain is worsening, or new development, or if the pain is recently worsened. We have to consider these complications, which include pancreatic cancer, pancreatic pseudocyst, or development of biliary stricture. And don't forget other causes apart from the pancreatitis related causes like peptic ulcer disease, which is more prevalent in this category of patients. This diagram is to show you about the central and peripheral neuroplasticity. This is the mechanism that they are describing. Even after the pancreatectomy, a group of patients is persistent to have to experience chronic pain. So this is the mechanism that they are used to explain this persistent pain. So this is the outline of pain management. So initially, every patient should be offered medical management, and then if the patient is not responding to this conventional medical management or the conservative medical treatment, then the further management is decided upon the presence of intraductal hypertension. So this presence of pancreatic duct dilatation, mainly the male pancreatic dilatation, is implicated as a sign of the presence of intraductal hypertension as the main mechanism of pain in these patients. So if the patient is having dilated pancreatic duct on imaging, which can be either due to calculi or strictures or maybe due to both, then the patients can be offered the extracorporeal shockwave lithotripsy or endotherapy or else surgery. So if there's no significant pancreatic duct dilatation, in which case we assume that there's no significant intraductal hypertension, in those patients we have to continue medical management, and we can offer endoscopic pancreatic sphincterotomy and interventions like celiac plexus block, and if they are still resistant for the management, as the last option, pancreatectomy. So medical management of pain, stopping smoking and alcohol is of great importance, as I previously mentioned, and the use of analgesics, the guidelines recommends to use the WHO pain ladder to guide your management. So initially, the patients can be started on paracetamol combined with adjuvant analgesics. The adjuvant analgesics are the drugs which have developed for other indications, but subsequently found to have an effect on neuropathy, especially on neuropathic pain. So the opioid, especially the weak opioids, can be used in short term, but strong opioids should be avoided as much as possible due to tolerance and the possibility of dependence. So out of this adjuvant, the adjuvant analgesics, the tricyclic antidepressants, antiepileptic drugs including pregabalin and gabapentin, and serotonin norepinephrine reuptake inhibitors like duloxetine can be used in combination with paracetamol or short courses of tramadol. Out of these drugs, pregabalin is the only drug which has undergone a randomized control trial and with proven efficacy. So management of pancreatic calculi. So symptomatic pancreatic calculi, the management can be depend on the size of the calculi. If there are small calculi, the patients can have undergone ERCP with stone extraction, either using a balloon or basket. If there are large size calculi, those patients are optimum for extracorporeal shockwave lithotripsy, which can be combined with either with ERCP or mechanical lithotripsy is also another option, and failing that, surgical options are available. And so if the patient is having extensive calculi or multiple strictures, and if there's suspicion of pancreatic head mass, those kind of patients are not very suitable for ESWL or ERCP. So those group of patients can be offered surgery straight away. So some facts about ESWL. So the best group of patients who are suitable for ESWL would be painful, large radiopaque calculi, ideally located in the head or body of the pancreas. But there are certain exclusion criteria, especially if there are multiple pancreatic duct strictures, if there are isolated pancreatic calculi in the tail region, and presence of cholangitis or coagulopathy, or even during the pregnancy. And if there is another calcified structure in the pathway of shock wave, then still it is not a suitable option. So pancreatic duct strictures, the options available for the treatment are ERCP with stenting, which can be the plastic stents, or if it's not responding, the metal stents are available, or the strictures can be dilated using balloon, and the multiple strictures or resistant strictures can undergo surgical procedures. So what is the place of surgery in management, in the pain management? So if there's non-response or inadequate response to medical and endoscopic therapy, or if there's extensive calculi or multiple strictures, they can be offered surgically. And the studies have shown a better long-term response rates compared to endoscopic therapy. And the available options are partial pancreatic resections, drainage procedures, and combined of partial resection or drainage procedures. And as the last resort, in only selected group of patients, total pancreatomy with islet cell autotransplantation is the last option. So, what are the other therapies available? Pancreatic enzyme replacement therapy has been studied in various studies. However, the results are inconclusive. At the moment, there's the latest, the American gastroenterological the guideline does not recommend pancreatic replacement therapy as a sole management for pain. And antioxidant therapy, which has studied in several, which has shown some efficacy in several studies. Again, but there is limited evidence, so they can be used as a trial, but these preparations are not readily available. And celiac plexus block is another option available, which can be done under radiological guidance by using the endoscopic therapy or X-ray guidance. The celiac plexus block can be offered a pain relief for only a temporary duration, like maybe up to 2 to 3 months. So it can be used as a temporizing measure, or you have to repeat it in intervals of 2 to 3 months when the patient recurs with pain. So moving on to pancreatic exocrine insufficiency. So the incidence is about 80% in the second or third decade from the onset of the disease, and it is more the onset is more earlier in alcohol-related chronic pancreatitis. They can present even within the first decade after the diagnosis. So what are the features, and how can you diagnose pancreatic exocrine insufficiency? So the clinical features can be weight loss or presence of malnutrition, which can be used in the anthropometric measurement, and the steatoria is only a late sign. So because the pancreas has a very large reservoir with regard to exocrine function, at least when more than 90% of the pancreas is damaged, the steatoria will manifest. But before that, the micronutrient deficiencies can manifest, including mainly the fat-soluble vitamins. And the investigations-wise, as a first-line screening, the fecal elastase test can be used. And the gold standard test for the diagnosis for steatoria would be 72-hour fecal fat excretion, which is a cumbersome test, so it is not usually practiced. And measurement of the micronutrients, including vitamin D level, calcium, magnesium, and INR, the prothrombin time, can be used. So when to use pancreatic replacement therapy? So when there is clinical or biochemical evidence of pancreatic exocrine insufficiency, the pancreatic enzyme replacement is indicated. So they are available as enteric coated microspheres or mini microspheres, which protect them from destruction by gastric acidity, and these protective coat disintegrate in the duodenum at a pH of above 5.5. So dose is minimum of 40,000 units of lipase, because the lipase is the most important enzyme because it is not produced elsewhere apart from the pancreas. So the enzyme supplementation is prescribed with lipase units. So 40,000 units with a male meal and 50% of the dose with snacks. That's at least 20,000 units. So it has to be taken with meals. So the response is assessed clinically, and what to do if the response is inadequate. So you have to check the compliance, and you can use a proton pump inhibitor if they are not already on, because by gastric acid suppression you can increase the duodenal pH, because in advanced pancreatitis the bicarbonate secretion from the pancreas also is impaired. So this gastric acid suppression has shown to increase the enzyme availability. And you can double the dose if there's no response, and still if there's no response clinically, then you have to think other causes of fat malabsorption, like small bowel bacterial overgrowth, which can be there in this kind of patients. Okay, the next topic could be the management of pancreatic endocrine failure. So the diabetes secondary to chronic pancreatitis is seen in about 1 to 4% of all diabetic individuals. And this is more commonly seen in alcohol-related and tropical calcific pancreatitis. The pathogenesis is important to understand the treatment. So the destruction of islet cell will lead to reduction in the insulin, and another important mechanism is because of this the nutrition maldigestion, there's impaired secretion of the incretins. So this in turn will reduce the reduction of endogenous insulin secretion. Apart from that, the destruction of alpha cells lead to reduced glucagon levels. This is important because they are more prone for hypoglycemia. And the reduction in pancreatic polypeptide, which is responsible for maintaining liver glycogen stores, is also important for to describe them more that they are more prone for hypoglycemia. So diagnosis is in every type of diabetes is similar, that we already know, and it is recommended at least annual screening in these patients for diabetes. So the management of diabetes is a challenging area in these patients because up to 25% of them can have brittle diabetes, which with marked swinging of the between hyperglycemia and hypoglycemia. And as I previously mentioned, they are at increased risk of hypoglycemia because due to loss of glucagon, they are inconsistent eating pattern and the carbohydrate malabsorption, and in patient with alcohol-induced chronic pancreatitis can have concomitant liver disease as well. So it is important to get the assistance of endocrinologists in their management. So the management include the components of management is same as other types of diabetes like lifestyle modification, pharmacotherapy, and screening and management of complications. So pharmacotherapy, metformin can be considered as initial therapy, but the problem is the frequent side effects may not be tolerated. The metformin may not be tolerated by majority of the patients. So in those kind of patients, insulin has to be prescribed, and insulin is first line in severely malnourished patients because of the insulin's anabolic effects. The glinides may be used in low doses, but the other classes of oral hypoglycemics are generally not recommended in this group of patients because of the side effect profiles, and they are more prone for hypoglycemia. And the most other important aspects of the management of the glycemic control would be adequate replacement of pancreatic enzymes, because as I previously mentioned in the pathophysiology, it helps to increase endogenous secretion of the insulin as well as reduces the incidence of hypoglycemia. So this is one of the key areas in the management. Then the screening and management of diabetic complications is also important. They are more prone for metabolic emergencies, and the microvascular complications are seen as frequent as other types of diabetes. However, it appears the macrovascular complications are relatively low in this group of patients. So then moving on to the management of complications of chronic pancreatitis. So this is a big area, but I would like to highlight only some important complications. So the complications as I previously described, the pancreatic calculi and pancreatic duct strictures, and the other possible complications are because of the fibrosis due to prolonged inflammation can cause strictures, biliary strictures, and narrowing of the duodenum causing gastric outlet obstruction. And pancreatic carcinoma is another complication especially in long-standing chronic pancreatitis. And the pancreatic duct disruption can be associated with pancreatic pseudocyst formation, and in turn it can be associated with pancreatic ascites or pancreaticopleural fistulae. And because of the inflammation, pseudoaneurysms can be formed especially in the splenic artery, which can rupture, can cause torrential hemorrhage, which can be life-threatening. And the thrombosis of the splenic circulation, mainly the splenic vein thrombosis and portal vein thrombosis, is also described in this group of patients. So I will describe some important complications in summarized form. So pancreatic pseudocyst, the prevalence is about 20 to 40% in chronic pancreatitis. So when to treat pancreatic pseudocyst in these patients? So if they are symptomatic, or if they are complicated, or if there is large size and if they are persisting, then the treatment is indicated. So what are the common symptoms? The abdominal pain is the most common symptom, and the complications would be infection, bleeding, or rupture, and causing surrounding structure obstruction like biliary or duodenal obstruction would be indications for treatment of pancreatic pseudocyst. So the methods of treatment will depend on the location, the size of the pseudocyst, and whether the cyst communicate with the major pancreatic duct. So what are the options available for the treatment? Endoscopic drainage is the first line option, and especially in uncomplicated pancreatic pseudocyst. So endoscopic drainage can achieve via two routes, either transmural drainage via the stomach or via duodenum, or using transpapillary drainage through the pancreatic duct. And surgical drainage is another option, and percutaneous drainage is now only considered when the endoscopic therapy or surgery is contraindicated or unsuccessful, then only the percutaneous drainage can be considered. Common bile duct strictures are due to fibrosis involving the pancreatic head, and it is important to exclude a malignant stricture in these patients. So taking brush cytologies and repeat imaging with MRCP is important. And every pancreatic duct stricture, the treatment is not indicated. Treatment is indicated only if they are symptomatic. That means if they are having jaundice or having cholangitis, or if there is persistent elevation of the alkaline phosphatase about 2 folds, or persistently high bilirubin levels, are the indications to treat pancreatic, the common bile duct strictures. So the treatment options would be ERCP, the biliary sphincterotomy, and pancreatic stenting. So the treatment options available for other complications are for the pancreatic duct injury, stenting can be done. Pancreatic ascites is another important complication which can be treated with pancreatic stenting or with surgery. The pseudoaneurysms of the splenic artery can be treated with angiographic embolization, especially if it is associated with pancreatic pseudocyst. Before drainage of the pancreatic pseudocyst, treatment of the pseudoaneurysm is indicated because there is an increased risk of rupture. The splenic vein thrombosis, the role of anticoagulation is doubtful. However, these populations are more prone to develop fundal varices. So the fundal varices treatment is with the glue injection and management of portal hypertension with beta blockers, as in other patients. So the key messages I would like to highlight in my topic are: it's important, multidisciplinary involvement is important in management these patients, and strict avoidance of alcohol and smoking. Adequate pain relief is important to improve quality of life, and adequate pancreatic enzyme replacement therapy is important both for nutrition management as well as glycemic control. And it's important to screen them regularly for malnutrition and bone health. Thank you for listening, and I would like to take any questions.
Thank you very much for your excellent presentation. Type of questions.
This is for the first speaker. He's asking, are there any commercially available forms for pancreatic exocrine failure?
Yes, there are commercially available preparations. There are several brands available. However, in the government sector, the pancreatic enzyme replacement the therapy is available. They are available as either 10,000 units capsules or 25,000 units capsules.
Yes, I must thank you also for your presentation. That was also very clear. You suggested that these patients with chronic pancreatitis should have frequent meals or more frequent meals. So that surprised me a little, because wouldn't that stimulate the pancreas more to produce more enzymes and cause more injury?
Yes. Actually, sir, that's the main reason for frequent small meals would be, one thing is with large meals, they might cause discomfort, the abdominal distension and discomfort, and the pain may be that may be more with large meals. And the frequent meals, the reason for frequent meals would be they are more prone for hypoglycemia, and so with the frequent more frequent mealing would prevent them developing hypoglycemic episodes. And they might, with a small diet, might be the available pancreatic enzymes might be sufficient for the compensation. That's another possibility.
Thank you very much, Dr. Vajira Tharanga, for your brilliant presentation.